My name is Diogo Moura. I'm here with my colleague, Vitor Brunaldi. We are both assistant professor at the endoscopy unit from Hospital das Clínicas of University of São Paulo in Brazil. We are here to talk about our recent published paper comparing APC versus MPC plus full thickness suturing in the management of patients with weight regain after Roux-en-Y gastric bypass. This is a randomized control trial. We are recording this video as a web meeting since in Brazil we are also facing the coronavirus disease and we are in a social distance following the government recommendations. So we're gonna talk about our paper now. So Vitor, can you discuss about our methods and results?
So the first issue we faced during the design of this pilot randomized trial was which kind of follow-up strategy we are going to define for the ablation group. We decided to employ up to 3 sessions every 8 weeks, every 6 to 8 weeks, because that's how most of the currently available studies report the APC treatment for weight regain. The second was regarding the suture pattern, which kind of suture pattern we're going to employ in the suturing group. Diogo?
So when we talk about endoscopic suturing, a lot of discussion regarding which type is the best option for patients. So we have the interrupted suturing and the purse string suturing, which is a continuous suturing. So some studies, especially from Chris Thompson group, showed that the purse string is better than the interrupted suturing. However, purse string is very challenging to perform. So just few endoscopes can perform this procedure. So in our study, we decided to perform a procedure between the interrupted sutures and the purse string sutures.
As to weight loss outcomes, we had this slightly superiority in favor of the APC alone in terms of % total weight loss and BMI reduction just at 1 month follow-up. For the 6 months and 12 months, there was no statistical difference. Yes. So in terms of weight loss trends, including only patients who attended to all follow-up visits, 1, 3, 6, 9, and 12 months, we noticed that there is different in terms of behavior. The APC alone group had earlier peak weight loss peak. They peaked at 3 months, while patients from suturing group had this weight loss peak at 9 months. Our longer follow-up is 12 months, so we don't know yet what's the meaning of this later peak in the suturing group. So as to our logistic regression, we looked at the baseline demographic data to look for any possible predictor of success, and clinical success was defined in our study as total weight loss greater than or equal to 10% at 12 months. Our only predictor of success was the percent of gastric retention for a solid meal at a pre-procedural gastric scintigraphy. We found that the more the patient retained at 1 hour after eating, the higher the chance that he or she achieved total weight loss equal to or greater than 10%. That seems contradictory, but we hypothesizes that maybe we are facing 2 different types of patients. Even though they are all referred as the same, they are all referred as Roux-en-Y gastric bypass patients, they are different. There are 2 kinds of patients. There are patients who had really wide anastomosis from surgery, and that pouch retention had no impact on his primary weight loss. And we have this other patient who had small calibrated anastomosis from surgery, and in time, his stomach dilated, and he lost this pouch retention that he had once at the early postoperative period. So if we try to shrink this patient with wide anastomos from the beginning, we're not giving him any advantage or favoring his weight loss, because pouch retention was not an important factor for his primary weight loss. Instead, for the patient who had the smallest calibrated stomas from surgery, he had this pouch retention as an important pillar of his primary weight loss. So if we shrink it back to the way it was before, maybe we can favor his weight loss again. So we think that maybe this gastric scintigraphy result points where this patient lies between this range of different Roux-en-Y gastric bypass patients.
This is a great finding in our study, and I think it was very, very important to understand which kind of patient will have a better response after the procedure. We know our study has some limitations, and we think a long-term follow-up is necessary to understand which procedure is better. Some other things needs to be analyzed when choose the best approach for the patient, such as costs and patient's preference. So when we talk about costs, we know, for example, in Brazil, if you perform 3 APCs, it's cheaper than perform just 1 APC and full thickness suturing. However, we know in the US, when you perform 1 APC plus suturing, it's cheaper than perform 3 APCs. Regarding anesthesia, suturing requires general anesthesia. And when we perform APC, we can perform under sedation. So some patients are afraid about general anesthesia, so sometimes the patient may prefer the APC just with sedation. However, as we discussed in our paper, when we perform APC, sometimes more than one procedure is required, and thus we may have more risk of adverse events related to anesthesia. When you perform 2 procedures, you have more risk than 1 procedure. So I think these are the main points of our studies and the main limitations, but we are sure our studies will help to better understand the role of endoscopy in the management of weight regain.
So that's what we have here to discuss today. I'd like to seize this opportunity to thank our other co-authors and collaborators. I'd like to thank our patients who we are happy to see they benefited from the procedure. And I'd like to thank the GIE editors for this opportunity.